In this lecture, we're going to be covering multicultural ethical values, biases, and how we can make sure as healthcare providers that we give everybody equal and fair treatment. Being a healthcare professional, we are going to come into contact with lots of people who not only have different cultures than us, but have had different experiences in their life, which are going to lead them to have a possibly different ethical value set than we may have. Regardless of that and our differences, we need to treat everybody the same, or at least as close to the same as we possibly can. We should give them fair and compassionate treatment regardless. But that compassionate treatment sometimes can vary from person to person based on their value sets, the culture that they come from, and some differences we may see based on that cultural difference that we have. First thing I want to talk about are some common bias types and how they apply to us in the field. There are more biases in medicine than you may realize. When people tend to set up systems and do research, whether they mean to or not, they inadvertently tend to skew towards things that are going to benefit them or people like them to some degree. It's natural human tendency that we see issues that arise for ourselves or those very closely around us. And because of that, those are the issues that we investigate and what we invest in finding new ways to do something or new ways to treat or address things. And this is what has led to biases being ingrained in medicine. The first type of bias I want to talk about quickly is confirmational bias. This is when you only look at clues that confirm the existing belief you already have, often ignoring other signs that would steer you away from that being the cause. Let's take you have a patient who is telling you that they're having chest pain, and you find them sitting in their car, and they might have just had a motor vehicle accident. And as they're telling you have chest pain, you're going to look for things like seatbelt signs. You're going to ask them about, did they hit the steering wheel? Does it hurt more when they breathe in or out? And you're doing a good assessment, but you're also pushing them towards that they have intercostal pain. So they're having pain of their thoracic cavity, not necessarily cardiac pain. And if we ignore some of the clues that the patient's telling us, like the chest pain started prior to the crash, you're using your confirmation bias. You are only asking questions and only doing assessment that's going to shift you towards what you already think it is, as opposed to what it might actually be. There's also self-serving bias. So this is attributing success to us, but pushing our failures onto others. This is going to cause us to not learn from mistakes and our part in issues that arise. And we see this as students. We see this as providers in the field and honestly people in their day-to-day life. When we have failures, we need to learn the lessons from them. Even if we truly feel that whatever happened, a patient had a less than ideal outcome, and you might not have really had anything egregious that happened during that call, but to put that blame and really to put the burden of carrying what happened fully on someone else without admitting where maybe we could have done better or our part in that will only hurt us and our future patients more. So we can't only carry our successes with us, we also have to carry our failures so that we can learn from them in the future. Sunk cost fallacy applies mostly as educators or FTOs in the field, but it can still, you can see it with some of your patients. And this is the belief that if you put work into something, you're deserving of a reward afterwards. So you're only going to feel that you need to focus, or you will only focus on something when you can see the gain that you'll get on the back end. This is where the idea of like cutting your losses comes from, that if you don't feel like putting effort into something will bring you a reward or boost your standing in the end, then you're going to stop investing in that in the end of the day. And honestly, we can see that with some of the patients that we treat in the field. So you keep going back to the exact same psychiatric patient, and they're a frequent flyer and you're very familiar with them. And you have tried investing in their care and showing them that you care and have compassion for them, but they're not seeking the help from your viewpoint. And because you keep having to come back and see them on calls, and you feel like they're not doing anything to help themselves, and you're not getting the reward of seeing them thrive, and you're not getting the reward of no longer having to go to them as a frequent flyer, you're going to stop investing in them. And that's really the worst thing we can do for patients like that. Again, every patient, regardless of how often we see them, regardless of what we're seeing them for, deserves our best every single time. A decline bias is favoring the past over the present. So this is where like we've always done it this way type of bias. Refusing to change or advance because that shows the proverbial decline in society from before. The worst is yet to come type mindset. Change isn't always good, but change is rarely bad. Making that conscious decision to try to move forward and better yourself, whether it's yourself as a provider, yourself as an agency, is important. And the death of progression is stagnation. So for us to refuse to change because this is the way we've always done it is what will cause you to start practicing antiquated medicine and not giving the patients the best possible medicine you can. You have to be prepared to change. It's not showing a decline in society. It's not showing a decline in medicine. It's not showing a decline in the service that you're working for. Again, change just to say you're changing might not feel or look like a great thing, but you do have to change and adapt at some point. And especially in medicine, there's a reason we call it practicing medicine, even once you're out of being a formalized student, because it's always a practice. We're never going to be truly, truly perfect in everything from a medical standpoint. We're constantly building upon our knowledge and finding new and better ways to do things, and we have to continue to look in that forward light and move with it. And then lastly is in-group bias, which is going to be something that we're going to talk about with the multicultural ethics side. And this is that some research and some theorize that this is considered to be an advantage due to evolution. But this is the idea that we need to protect those that are most similar to us because it promotes your line. It furthers your stance and your place in society and ensures that people like you are able to continue on, that your bloodline is pushing forward. This honestly is a big issue for healthcare in general, not just pre-hospital medicine. So looking at all of those biases and how they're going to relate to some multicultural ethical issues and stances can be a tricky slope to go down because, again, we are going to see people that have vastly different cultures and life experiences, which has led them to have a very different ethical set than we do. And just because a patient and the way they want to be treated does not fully align, or the lifestyle that they are leading does not fully align with your ethical values, does not make it innately wrong. And that is very important to remember, that to them and in their eyes, your ethical values may not be correct because it is not from their culture. It is not from their life experiences that have shaped those within them. It does not mean it's wrong. It's just not theirs. It's just not yours. We need to push past this and treat our patients. It does not matter how different they look and they act than you. It doesn't matter that they don't have the same beliefs as you. That should never get in the way of you doing your job. And when it does, it's entirely bias related. So looking at some long-standing biases in healthcare. And here's where it's a really tough pill to swallow. And up until this point, if you have practiced in medicine before and you're expanding your scope now, and these aren't conversations you've had in the past, I can't fault you for the biases that you're going to have. I can fault you from this point forward if you do not strive to give every patient the best and push through some of these biases. Healthcare is innately biased. Like many professions, healthcare was built on the backs of people who were considered less than or looked different. And that is a very tough pill to swallow. People who were considered to be in minority, whether it's from race or from gender, were often preyed upon with the excuse that we are serving the greater good. So because I'm going to be able to fix and help all of these people, this one person is going to be more or less my sacrifice for that. And until ethical boards were really set up for medical research, there was a lot of praying that was done, which is devastating. And where we're seeing that kind of ripple through leads all the way back to education. And it's our educational practices and the things that we teach you are based on the research that was done that was predatory. And even though it was being researched and confirmed on minority groups, it was almost always from a light of how can we serve the quote unquote greater good, which was the majority. So it's that in-group bias. Yes, I'm researching with these people, but it's to help those, not them necessarily. So when we approach patients, one, regardless of their ethical beliefs, regardless of their religious beliefs, regardless of their sexuality, their orientation, who they're married to, if they're married at all, none of that matters when we're treating them. We need to treat them with the highest level of care, the highest that we can possibly give them, the most compassionate, ethical care that we could possibly bring forward to that patient. And that includes respecting their beliefs. So if they're of a culture like a lot of Asian cultures and really Hispanic cultures as well, that do not feel comfortable with men being alone with women that are not family, respect that. If you're both men on the truck and you're not able, or the man has the higher level of care compared to the female on the truck and you're not able to honor that for the patient, have that discussion with them. But do the best job that you can while respecting their beliefs, while respecting their wishes. And if you're unsure of every cultural belief that's out there, that's perfectly okay. Now would be a good time to start reading into some of them, but also just conversing with your patients. They understand and they very much realize you look different than them. So having those conversations of, do you feel comfortable with this? I will be the person handling your care. This is my partner. And if they say, no, I don't want you, I'd prefer her, or I don't want you, I'd prefer him, try as kindly as you can to figure out why and then adapt to that request. Now, some of your healthcare biases. They were set up, the healthcare system in general was kind of set up skewed towards white men because that is who was doing the research. So we can see this all the way down to like your monitor interpretations. When you put on the cardiac monitor, it is set for a 45-year-old white man. And we know that, and we can see that because something that is completely normal in African-American male populations will come up as an abnormality through your cardiac monitor when it's doing that rhythm interpretation. So knowing that those biases are there and then starting to push past them are important. When you look through your books, very rarely does it show you skin sign changes in people with darker complexions. And this is kind of twofold. One, think of who was researching medicine. Two, while it is easier to see those or to demonstrate them in a textbook on the lighter skin tones, that doesn't mean you won't see them in the field on a darker complected person. So you, as a learned student, need to be prepared to put in a little bit of extra work when you get to those chapters and go out and seek resources where you can find what skin sign changes would look like in people with different skin colors. You will not see notable cyanosis most of the time until it is very, very, very advanced in very dark complected people. But you'll see other changes. So you'll see that they start to get a little ashen. They maybe get a slight gray looking to them. It's not the blue cyanosis like we expect to see. It's slightly different. Us only looking for certain skin sign changes as they're related to what we have directly learned is a bias we have to overcome. Other cultural biases or biases that are in medicine that are taught to you are what's considered appropriate treatment. And students who have gone through these lectures with me before, we have had heated debates in classrooms as it relates to the visual presentation of somebody in pain. Your job as a provider is to give your patient the best possible medical care, to address what is going on with them and treat them accordingly. This idea that for somebody to be in pain, they have to show lots of changes within their vital signs and that they have to be rolling around and screaming is just flat out wrong. In many cultures, it is weakness to show pain. And so from a very young age, they have been conditioned to hide when they're in pain, to not let that show. So whenever we get called to them, and we have a little bit easier time rationalizing it when it is a traumatic injury that's causing the pain. We can see that injury. We can empathize because we see the injury on how badly that might hurt. So where we really get ourselves into trouble and we drastically undertreat our patients are whenever it's something that you can't necessarily visualize. Things like chronic pains, chronic back pains, sickle cell crises. We don't see oftentimes that visual representation of pain of how we have been conditioned and told you're supposed to see it. And so we can tend to minimize the amount of pain that the patient's in. Just because they're not telling you it's a 28 out of 10 and they're not rolling around and screaming doesn't mean that they're not experiencing significant pain, which means we need to listen to our patients when they're telling us in pain, and kind of regardless of how exactly they're presenting. If they have a complaint that includes pain and then we do assessments and we can find positive findings of pain in our assessments, we need to be addressing the pain. And addressing the pain and managing the pain doesn't always have to be with narcotics. And as you get through some of your treatments in later chapters, I'll talk about the different ways that we can manage pain. But you need to be managing it even if you don't react to pain the same way they do. Down in the Low Country area, one of our instructors who teaches with us also teaches at a college, and they had a young woman who was going to school there that get diagnosed with sickle cell anemia until her 20s because she was Nigerian, and her whole life her family had told her that she doesn't react to pain. To react to pain is weakness, especially as a woman. And so she just needed to bury it down. And it was during physical strenuous exercise that she ended up having a syncopal episode. They took her to the hospital. She was in sickle cell crisis. She had sickle cell, a very painful disease process that 100% can be life-threatening for her entire life. And it wasn't until in her 20s that she finally got diagnosed because of her cultural reaction and how she had been told to react to pain. So this entire time up till that, if she was not reacting the way you expected her to be to pain, would you have treated her? And the answer should be yes. That you do treat patients whenever they have those complaints, even if visually they're not presenting the way you expect them to. So how can you help confront your biases? The easiest way is to remember that you're going to have biases, that you have inherited biases, and to push past those. To not let your inherited biases that come from medicine and how medicine was set up drive and dictate your care. To remember our past, but also to push forward and to treat every patient equivocally. Give them all the exact same, that your best is all your patient ever deserves. So give that to them. Even if they're different than you, even if they believe and they act different than you, you should do that. If you have any questions, please reach out to your instructor. You can also reach out to me. This is something that I'm very passionate about and happy to continue these discussions. Thank you.